Good morning, good afternoon, good evening, everyone. Welcome and thank you for joining today. My name is Manda Limbu, Senior Manager for Advocacy and Civil Society Engagement at FB 2020. Before getting started, I'll quickly review key logistics for today's webinar. First, in addition to today's presentation, you should see a Q&A pod where you could submit questions. Please feel free to add questions in English and French. If you experience any technical difficulties, please use the chat box. In the event you're unable to reach us or need to email us, please email ybai@familyplanning2020.org. We'll add that email to the chat box. Today's webinar will mainly be in English, but there is simultaneous interpretation into French. I will share instructions for hearing the French translation, and then my colleague Yassine will repeat in French. We've also added those instructions in English and French in the chat box. Before we start the webinar, everyone needs to select a language option. Please look at the bottom of your Zoom screen and locate the globe icon that says interpretation. Please select your preferred language, English or French. If you're choosing French, you can click on mute original audio if you don't want to hear the English translation in the background. Please also disable your video as it may affect your connection. And finally, this webinar is being recorded. Thank you again for joining us and for your participation. I'd like now to invite my colleague Yassine for translating these instructions. Yassine.
Bonjour à tous.
Good morning, everyone.
En anglais, mais il aura une
It will
interprétation
be
en
a French and English version.
Avant de commencer le webinaire,
Before we start this webinar, I'm inviting you to choose your linguistic option. To the bottom of the screen, you'll see the little globe icon. Choose your language, French or English. If you choose French, you can also mute the original sound in English if you don't want to hear it in the background. If you are on a mobile device,
ensuite, appuyez sur l'interprétation linguistique.
Press star and then interpretation for French or English.
Si vous avez des questions à ce sujet,
if you have questions,
me poser les questions dans la boîte
don't hesitate to ask me questions on the chat box. Thank you very much.
Thank you, Yassine.
Merci.
Without further ado, I'd like to welcome our moderator, Dilly Severin, Senior Director, Global Initiatives at FB 2020. Unfortunately, our colleague Mercedes, who was supposed to moderate this webinar, could not join because of a family emergency, but we are very, very happy to have Dilly moderating the session today. Dilly, over to you.
Thanks, Monday. Good morning, good afternoon, good evening, everyone. I'm going to run us through just our session objectives for today and talk a little bit about our format. We have several esteemed presenters with us this morning. So each of them will give a short presentation, after which we'll pause for some questions from the audience. And then we will have a quick wrap up at the end. Because we have translation going on, there are moments where I may pause just to give our translators some time to switch over, etc. So please bear with us, and we thank you for your patience ahead of time, just to make sure that this runs very smoothly. So without further ado, let me take us to our session objectives for today. All right, so today we're gonna share key aspects of the new WHO guidance on maintaining essential health services to safeguard sexual and reproductive health and rights during COVID-19. We're also hoping to propose additional topics that can be included in the new WHO guidance and in country-specific guidelines, and we'll hear from some esteemed colleagues from different countries as well. And we're hoping to end with some concrete policy, programmatic, and budgetary actions that civil society and governments can promote to implement the guidelines at the national and subnational levels. All right. Sophie, can you take us to the next slide, please? So it's really my pleasure to introduce James Chiari, who is with the Department of Reproductive Health and Research at WHO. James is the head of the Contraception and Fertility Care Unit. He's going to share with us some key aspects of the WHO guidance on maintaining essential health services, including SRH, during COVID-19 and plans for implementation. So James is going to present for about 7 to 8 minutes, and then we will take some questions and answers from the audience for about 7 minutes. So James, welcome, and over to you.
Thank you very much, and it's a real pleasure for me to have this opportunity to talk and discuss with all of you regarding recent updates on WHO guidelines, particularly focusing on reproductive health in the context of the COVID pandemic. And if we could have the slides, please. Yeah, so at the onset of the COVID pandemic in March 2020, WHO realized this challenge of maintaining essential services, and a guidance was issued, which was the operational guidance for maintaining essential health services during an outbreak. These guidelines have recently been updated, and the update was issued at the beginning of June, and looking at maintaining essential health services, but with a very specific addition of a second part, which is the life course and disease considerations. So on the next slide, when we look in more detail as to what is in this update, can we move to the next slide? Yeah, so when we look at more detail on the operational guidance, now it consists of 2 parts. As I said, part 1 is what was developed back in March, and part 2 is what has been added now in June. For my presentation, I'll be focusing on the second part, but we need to be aware of the contents of the first part, which are really looking at health systems and what needs to be done in the COVID pandemic context, issues about governance, optimizing service delivery, patient flow, and workforce, and so on. So all these things are covered generally from a health system perspective in part 1 of this guidance. And on the next slide, so the part 2, as I said, is the one which added these life course and disease considerations. So this is more specific to the program areas that we work on. And it is divided into 3 parts. There's the life course stages, which has maternal and newborn health, child and adolescent health, older people, and sexual and reproductive health services. For our discussion tonight, we'll be actually focusing on the sexual reproductive health section of the life course stages. But for those who may be interested, there are other 2 sections. One is on nutrition, non-communicable disease and mental health, and the other one is looking at communicable diseases. And the next slide, please. So the sexual reproductive health services has a background section, and all the sections in this guidance are developed more or less the same way. They all have a background section and then a section on specific recommendations. So generally on sexual reproductive health, the focus is on this issue of universal access to SRH services and reproductive rights. It is aligned with the program action of ICPD and the Beijing Platform of Action, and also the SDG targets 3.7 and 5.7. Importantly, It draws lessons from the Ebola and Zika virus disease outbreaks, which, as we know, had very serious repercussions on sexual reproductive health services in terms of demand and in terms of affecting the impacts of lack of access to services. The impacts are focused on unintended pregnancies, unsafe abortion, on vulnerable population, and access to essential and emergency care. And we prioritize digital health services, self-care interventions, and task sharing and outreach. And the areas are prioritized because of our knowledge that this will be the new normal in terms of the way we can provide services. And on the next slide, looking at the recommendation areas. So the recommendations on sexual reproductive health are organized as in the table above. So we have the program activities, the modifications for safe delivery of the services, and what needs to transition towards as normal activities are restored. I will highlight which are the areas of sexual reproductive health that are covered. It covers access to contraception, fertility care, safe abortion to the full extent of the law, and post-abortion care, sexual health, cervical cancer screening and prevention, and addressing violence against women and girls, including gender-based violence and sexual violence. For this session, I will not go into each one of these, but I will look at the accessing contraception and look at what are the modifications for safe delivery of services and what should be done as we transition as an example. And for those who may be interested, you can go to the actual guideline, which is available on the WHO website, and you can be able to read for each of these areas. So next slide. So for contraception services, what are the modifications for safe delivery of service? One, we know that a woman's regular contraceptive method may not be available, and other contraception options may be what is needed at this time. So we highlight methods that can be easily delivered if the contraceptive choice of the woman is not available. These include barrier methods, fertility awareness-based methods, and emergency contraceptives. These methods should be made more readily available in the context of responding to the COVID pandemic. Then the other recommendation is to relax the requirements for a prescription for oral contraceptives or for self-injectable contraception where this is allowed, and also for emergency contraception. And we know in many countries, these methods usually require a prescription, but this is an area that can be relaxed considering that access to prescription may not be feasible during pandemics as we are facing now and the shutdowns. And also WHO guidelines actually do recommend that these methods can be accessed without needing a prescription. And the other recommendation is to provide multi-month supplies with clear information about the method and how to access referral and care for adverse reactions. The other recommendation is really to enable pharmacies and drugstores to increase the range of contraceptive options that they can provide, and also to allow for multi-month prescriptions and self-administration of subcutaneous injectable contraceptives if these are available. As you can see, this recommendation is actually targeting the platforms and mechanisms through which women access contraception. And we know that through pharmacies and drugstores, it may be easier during this time of a shutdown. And on the next slide. So what about as we transition towards restoration of activities? It is important to plan for clients to return to longer term methods, which they may not have been able to access during the lockdown, such as IUDs and implants, and even permanent methods, such as tubal ligation and vasectomy, if these services were disrupted. It's also important to assess inventory and maintain data related to procurement of medications for contraception to avoid potential stockouts. And this is important during the pandemic and also as we transition. Also to monitor and communicate about where services can be accessed. This is particularly important in transition because as services are opening up, many times clients are not aware that these services are now running, and therefore they continue to not access them. So it's important during the pandemic for clients to know where they can access the services, but also importantly as we transition to make them aware where services have now become available. On the next slide. So I think it would be a disservice for this presentation if I didn't say something about adolescents and young people. And this is because they have special needs, and their needs do not go away in the context of the pandemic. Even when there is lockdown, the need for adolescents and young people for sexual reproductive health, including for contraception, continue. And they are also particularly vulnerable. And particularly they are vulnerable to increased gender-based violence, sexual abuse, and unintended pregnancies, which we've also all seen reports about in various media. What we need to remember is that adolescents are not one homogeneous group. They are heterogeneous with different needs and preferences. And these differences may be even more pronounced based on their circumstances in the context of COVID-19. They usually have specific challenges in accessing contraceptive information and services, even when there is no pandemic, but this may be more pronounced during this time, particularly if school and community-based services have stopped. And we know that biases about adolescent sexualities may even become more pronounced. And data and evidence on adolescent contraceptive services is often lacking. And this, despite the fact that this information is key for us to be able to make a decision and to understand what is happening. So on the next slide. So what are the specific modifications that we need to do for adolescents and young people? One is to provide information about where and how they can access contraceptive counseling and services. And also consider establishing alternative delivery modalities that are more accessible to adolescents. And setting up hotlines specific for adolescents, which can provide information and advice in a user-friendly way, and that adolescents can be able to access. At the health facility, for health facilities that are running, it is important to ensure that adolescents continue to have access to the full range of contraceptive methods that are available, including condoms and emergency methods, and also to consider waiving restrictions if this exists. WHO does not recommend any age-based restriction or restriction based on marital status or parental or spousal consent for any method of contraception. But we know that in some countries there are these restrictions, and this can be really a hindrance to service access for young people and adolescents. And also to continue ensuring that services are provided discreetly and confidentially. And next slide.
James, can I just flag? We have several questions already for you in the chat. People are very intrigued and excited. So just wondering if we can close the presentation portion soon so we can get those,
yes,
get to those questions. Thank you.
Yeah, we just have, I think, about 3 slides. So this slide I put is on another WHO guideline, which is the community-based healthcare, including outreach and campaigns in the context of COVID pandemic. This is a joint guideline by WHO, UNICEF, and the International Federation of the Red Cross. This is another guideline that you can access, and it has information on campaigns and outreach for contraception. And the next slide, to remind you on another resource that we have on the WHO website, we have a question and answer section that you can be able to access. And I really put this slide to also highlight that although these are the global WHO guidance that we are talking about, countries have gone ahead and developed national specific guidelines, which could be guidance, could be interim guidance documents, could be guidance notes, called operational guidance, but under various names, various countries. And this is just an example of some countries that have either completed or are in progress of developing guidelines. And this list is not in any way exhaustive. So in terms of WHO, we work in very many areas and provide technical support in many areas. And to end, I just wanted to flag on the next slide that one of the things that we are supporting is sharing of practices and experiences. And if you can move to the next slide. Yeah, we can skip, in the interest of time, we can skip this slide. Yeah, and it looks like one of my slides was not included, but I wanted to give a plug for a task team that we have formed under the Implementing Best Practices platform, where various partners and the Ministry of Health and WHO colleagues have frequent discussions on areas about contraception and share experiences of what they are doing in the country. Thank you.
Thank you so much, James. So we have a few quick questions for you before we move on to Peter. So one question is about cervical cancer screening. What is the importance of maintaining screening if treatment is not yet possible? Can you take that question?
Yes, so I think cervical cancer screening is very important for many reasons. And screening can be done in many ways, including through self-sampling for HPV. And therefore it is feasible even during this time. Cervical cancer screening is important both in terms of detecting those with precancerous lesions who can access treatment, but also in assuring those that do not need treatment. And it is important to continue screening at this time, because if we do not do the screening, although we know this is a disease that is slowly progressive, we will miss out a lot of opportunities. Another importance of cervical cancer screening is that it also picks up a lot of early stage malignancies, which can benefit from immediate treatment that is still available. And as we know, the outcomes for cervical cancer are very different depending on the time the disease is detected.
Perfect, thank you, James. We also have one question about whether you can share any statistics on sexual and gender-based violence. What statistics does the WHO have on these issues?
So as you know, gender-based violence statistics tend to be very unclear, and often they underestimate the actual prevalence. We do have some reports from studies that have been conducted in country and specific during the pandemic that have shown an increase compared with the previous prevalence. I do not have off my head like exact numbers, but we do have global statistics, we do have national statistics, and but we know that these vary a lot depending on context. You have to know that this is something that is not always reported, and the statistics we may have may really grossly underestimate the magnitude of the problem. But you can check on the WHO website under gender-based violence, and you can be able to find some of the recent statistics that are available there.
Perfect. Thank you so much, James. We're going to pause here and switch over to our colleague, Peter Ngure, and then we will come back to other questions for you because there were some others in the chat. So thanks again for your presentation. And then it is really my pleasure to welcome Peter Ngure, Policy and Advocacy Team Lead at the Pathways Policy Institute in Nairobi. Peter is also one of the GATE's 120 under 40 family planning leaders. So welcome, Peter. Please go ahead with your presentation.
Thank you very much. I would want to start with the background of where we have come from, is where James has left. When the WHO was able to issue the guidelines at their level, Kenya started the process of sort of domesticating the guidelines so that they're in line with the Kenyan law and the Kenyan constitution, but also to give direction, because we're having a lot of challenges with access to RH in our facilities. And so in the month of April and May, the practical guidelines were issued. And to support the guidelines, the Council of Governors also issued a statement that a few partners worked on to help in continuation of essential services because of the realization of the stockouts that was happening, but also a lot of stigma that was going on because people were not, especially women, were not going to the facilities. For us at Pathways Policy Institute, we immediately commented on the draft and were able to give some of our inputs into the draft, especially around trying to create an algorithm for family planning, which is still missing even now. But we were able to link up quickly with the Division of Reproductive Health, and we became, Laikipia County became the second county in the country to disseminate the guidelines to its staff, especially the county health management teams and the sub-county health management teams. And through that conversation, we were able, as a county, as partners, to push the county to invest in the following. Right now, Laikipia County has developed telemedicine for family planning, where we have 4 toll-free lines that are being used by the county coordinator and the 3 sub-county coordinators to just be able to help women who call in for FP advice counseling services and to book appointments. We have also been able to integrate the COVID team here has a freight service where they're able to evacuate the patients for COVID. So the same service is being now used for maternal labor and SGBV evacuation, especially during COVID times. We've also been able to domesticate the algorithms. But as I mentioned, one of the challenges we have is that the national government created 4 algorithms, but family planning did not get its own algorithm. And so it's put together with the intrapartum postnatal algorithm. And that is what we are working on at the moment. On some of the lessons we have learned as a team is that county ownership of the process was extremely critical because as you would realize, reproductive health was not top priority when we talked about COVID in the counties. The challenges we are having of bed capacities, lack of isolation wards, lack of quarantine spaces, lack of testing in the counties are seen as higher challenges than SRH. And so SRH was being sort of put at a second level by the counties. At the level of health workers, we've also realized the challenge that health workers are stigmatized in both ways. They may not have the required PPE so that to work with women, and especially during deliveries, and these are vaginal deliveries, which they have a challenge with. But also they are stigmatized at home. When health workers come from the facilities, especially the RH people, there's always a challenge that they are seen like those guys who are COVID guys. They're actually called COVID guys. So we've had a challenge with that, but we've been working on awareness and sensitization. And the county government for Laikipia has taken up to doing this on radio. We are having a radio program every Saturday to be able to ensure that that is dealt with. The other challenge has been on booking appointments, because now with telemedicine, women are required to book appointments so that they can come and receive their commodities or get their refills. And the challenge with this is that you have to stagger women so that, as James has presented, we need a certain number of women coming to the facility at a certain day. And this has not been the practice traditionally in our communities, because most of the women will come to the clinic during the market days when they're able to travel. So we have had a bit of a challenge dealing with that. And the only thing we are seeing as a success is that women are learning how to use the toll-free line, and then they're able to call and book appointment. But this has not been a practice. Moving to the budget issues, at the national level, we saw a drop during the supplementary budgets that were submitted in April. The budget for reproductive health, reproductive maternal, child, and adolescent health dropped with about 2 billion from 6.1 to 4.4. Well, we have been advocating to ensure that this money is restored to the 6.1 billion. The 2021 budget still has a big challenge because it has again dropped by about 300 million. So there's a lot of work that as partners we need to undertake to ensure that on funding we are able to get back our monies. And this is the same challenge, finally, as I finish, we are having at the county level, because with a county that was investing about $10,000 to reproductive health outreach work, we have dropped to about 8,000, and subsequently we are seeing it continue dropping in the subsequent budget. So what we are doing currently, the budget cycle and the budget advocacy time is ending today, and a lot of partners have presented memos to ensure that at least the funding for reproductive health is not lost, even as we continue trying to push for more funding and more resources for reproductive health. So in a nutshell, that is what we are doing, and domesticating the guidelines at the county level, but also ensuring that partners are able to back up a bit of resources so that the continuation of services is realized. Thank you.
Thanks so much, Peter. You've touched on some of the challenges already that have emerged in the process. But I wonder if you can give us a little more detail now that you've gone through your slides on, as part of the lessons learned from Kenya's exercise on producing this practical guide, right, for the continuity of reproductive, maternal, newborn, and family planning care in response to COVID. What has been the importance of advocacy for the release of funds in terms of the budget advocacy we're talking about and all the partners who are involved in that? Can you just talk a bit more about the importance of that advocacy?
Yeah, I'll mention the one for Laikipia, because Laikipia is a county in the Rift Valley of the country. We had a challenge. We realized that in April, that about half of the budget for reproductive health had not been released. And we also realized that during the supplementary budget, that this was one of the areas that was being seen as an easy takeaway, because then the advocacy was not as much to this, and everybody was pushing for brick and mortar. Everybody wants to have more beds. Everybody wants to have more isolation centers. And so together with the Laikipia Civil Society Forum, which we have formed of about 8 civil society organizations, we have partnered to at least present the details of how much has not been spent. They had not spent about 500,000 Kenyan shillings in reproductive health. This was meant for outreach. And we together as partners, we were able to highlight to the government on the guidelines, the COVID, the RH COVID guidelines, practical guide. And we told them this is where we would want to see you put in the remaining balance of your money, the 500. And we have had a success because that's the money that they used to buy the toll-free telephone lines, and that's the same money that they have used to disseminate. And currently they are developing the FP algorithm so that in line with the national government guidelines. So that happened at the county level. At the national level, we are still challenged in seeing supplementary budgets leading to loss of money for reproductive health. And not only for reproductive health, I would want to mention that even for the national health budget, when the supplementary budget was presented, the national government cut a funding for health for about 1 billion Kenyan shillings, and that was moved to the COVID work. So COVID is not really is managed by a central committee, and that has been moved. And from this year, we are also seeing at the national government the total health budget still reducing, and so there is a lot of advocacy and civil society work that is ongoing currently to just ensure that we are not deprioritized, because the key word is that we see as if we are being deprioritized as the SRHR community as we move forward. But this is not only for SRHR also, it's also for immunization, it's also for non-communicable diseases. So there is a huge need for partners to come together and keep pushing and ensuring that at the national and at the sub-county levels, their funds are still maintained for SRHR. But what the county governments are also asking us as partners is, so what exactly do you want us to spend money on? And so this week we have been working on the key outputs for their program-based budgets, because as much as we push for actual amounts in the budget, if the outputs and the indicators are not clearly marked family planning, they will be lost within the basket. So that's also something that we're also asking partners to keep going on, and as civil society we are working together on that. Thanks.
Thanks, Peter. We have a clarifying question in the comments about the algorithm which you've referred to. Can you just explain what you're referring to there? A few folks want to understand better.
The guidelines have a lot of sort of award explanation. Then at the end of the guidelines, there are algorithms that have been developed. It's just a guide of when you get to the facility, what's the next step, what's the next step. It's a guide, a step-by-step guide on how to offer services, what to check for, how to screen, when to screen, where patients should move. If they screen positive, go to the next level. If they screen negative, continue with the services. So it's sort of a guideline that helps, a visualized guideline that helps the healthcare provider just see exactly where to take the patient next when they manifest, whether they manifest COVID symptoms or they don't manifest. So there's no algorithm for family planning. There's the first algorithm is antenatal clinic, hospital outpatient care for all patients. The second one is intrapartum postpartum management. The third one is neonatal care for women and suspected COVID cases. And the fourth one is on SGBV. But in the document, there's a whole 3 pages that cover family planning and contraceptives. And so for us, we are looking at, can we have this very specific algorithm developed at the national and at the county levels?
Thanks so much, Peter. We have several other questions, so I'm gonna briefly move on to our next panelist, but please do look at the chat, and if you feel comfortable, feel free to answer any of those in the chat. We'll try to come back to as many as we can if time permits. So thanks again, Peter. And I'm gonna move on now to introduce our next panelist, Dr. Yasmin Kazi, who is the Senior Advocacy Consultant for the Bill and Melinda Gates Foundation based in Pakistan. Dr. Kazi is going to talk to us a bit about how Pakistan has been responding to COVID and the guidance that has been delivered. So I'm hoping that Dr. Kazi can walk us through some of the key points and some insights on implementation guidance, as well as the role of donors and other partners in what Pakistan has been moving forward. So please, Dr. Kazi, we welcome you.
Thank you so much. And I'm really pleased to be here, and thanks for inviting me and including Pakistan into this important conversation. So in Pakistan, we have heard in the first presentation where the example was given, we had a complete lockdown. We had a first case of COVID by end of February, but Pakistan is a devolved system. So every province is like independent and health is completely devolved. Just to give a context, a bit of a context to those who maybe are not aware of systems in our country. So Sindh, where I'm based, which has the biggest city, Karachi, which is now the epicenter of the virus, the Sindh moved really quickly, and they imposed the lockdown on 14th of March. And at that time, there were less than 300 cases, and there was like only one death. But even at that time, very brisk actions were taken. But for 2 weeks, of course, there was complete fear and there was complete confusion. Everybody was just fighting with the virus, and nothing was paid attention to. And we suddenly realized of all the women who might be pregnant at this time, and more importantly, who would be needing some kind of services, and the infants who will be born of these from these pregnant mothers, and the current user of family planning, and if they need a resupply or if they need any method, what would happen? So we started looking at the landscape, and we quickly came together. When I say we, it means a lot of our partners, which are civil society, are NGOs who are very, who are vocal, who are active, and who have the community intel, who know where to go and where to do that. And so we looked at the landscape and we collected some of the key advocacy asks, which is like right now in my slides. What we realized that we were able to move some of the provincial actions. Like Sindh was very quick. They came up with the family planning reproductive health guidelines, which was, and we have a women minister, health minister in Sindh, who is our champion for family planning. So she quickly approved it. So we had a guideline, it was approved on 21st March so quickly, and it covered most of the element, and I was very happy to hear most of the thing in the first presentation, it's covered. But the major part of the work is being done by the disaster management agencies, and they have their own SOPs, task force, and guidelines. And we realized that reproductive health and family planning services are not classified as essential services. And our standard ask is that they should be classified as essential services in all settings. It's not that it's a COVID crisis, so we are calling it essential services. From a women's rights perspective, it is an essential services. And then we also realized, although there is a very high level task force on COVID that was put up at the Prime Minister level, but we need family planning and MNCH experts in that to guide the guidelines. And then, of course, the ask is so huge, the government cannot do it on its own. So private sector partnership, the NGOs partnership is essential from both demand and supply side gaps for filling in those. And then, of course, some of the things that we heard from the WHO guidelines, we already proposed that as early as 21st March, that, women's self-care should be the way forward, because women in lockdown are not able to access contraception. We have one of the biggest lady health workers program in Pakistan who does home visits, but they were not doing it because first they're scared themselves, they are not having protective care, and then women will not allow them in. So emergency contraception and self-injection of DMPSC, to scale that up, it is being done in Pakistan, in Sindh, but at a very small scale. And then we know from the previous disaster, which was not the health disaster, but we had an earthquake in Pakistan, which had a massive destruction. And then we had some massive floods. And we have learned the lesson that all these times the family planning, reproductive health fell into creeks, and the gender-based violence, the sexual violence, the unintended pregnancy, the unsafe abortions are so high. And of course, because of COVID, very peculiar kind of a strategy of lockdown and everything, mental health is a major issues. But that means that we have to train the providers to quickly recognize these things, to bring them into the forefront and to meet the demand. And then we also realized that all of us, including us as donors, but our partners and government, everybody is working on their own communication materials, some of the guidelines, and we need a lot of coordination. Because one thing we have learned, and I think the entire globe has learned, that if you do not communicate, you do not coordinate on the communication messages, that there is more confusion than anything else. So how do we do that? And then, of course, we also realized that family planning alone may not be as powerful at this time if we, if we piggyback with a larger agenda like MNCH, because everybody was, after some time, everybody was very concerned about pregnant women. So post-pregnancy family planning, post-abortion family planning. So we aligned our agenda with the other health calls. Very quickly, the digital health telemedicine came up. Okay, it was already coming up in Pakistan, and it became like the strategy at every forum. And this is now, and even I just came out from a meeting to join this webinar, and this is our Alliance on Post-Abortion Care, and they are even training the digital health providers to inform and talk about, how to take the correct doses of meso and how to guide them in the women's self-care model. And then, of course, I've already talked about the information, the dissemination, and how do we reach to the women in need, and accurate and new information, because women are very confused. If we are COVID positive, should we take a contraception? Should we not? And is it safe to take an injectable when there is a COVID crisis? So I think we have new questions. So we have to have new informations, and we have to adapt our counseling. And all these things, we quickly try to see how can we adapt to the what are we calling the new normal, which seems like, digital training, the capacity building, even the VCAT training, the value clarification and attitude transformation, removing biases from the providers when they are meeting the women. So, how can we do all of that stuff through digital platform? And this is a slide just to show the UNFPA has done some very quick work and the research to assess the family planning disruption. And this is an estimate, but this is a potential impact. So currently we have 8 million women who use modern contraceptive method, and the method mix is according to the DHS. And we have a very high unmet need in Pakistan, 5.5 million women. And then, of course, the unintended pregnancy. And then, of course, induced abortion that results. So these are the upper one are the one which are the current figures. What is expected because of the disruption of the supply chain and because of the disruption of the closure of the service facilities, it could be 10% decline, and the numbers are huge as a result of that. It could be even 20% decline in the use of modern contraception, and the numbers are even bigger. And stockouts, the issue of supply chain, and all those things which are extremely important to really look at very quickly, start working from now. So we have stocks for 6 months right now in Pakistan, but by the time the procurement and the shipment would come, it can go to, it can become a real stockout situation. So how do we measure that? And this is really a kind of a data that we are using to convince government to put the resources. My colleague was talking about the budget advocacy. We do that all the time. And this is the right time to do a budget advocacy, because there is a budget season in Pakistan in June. And we know that we need more resources for health and family planning. And this is where we are trying to see how we can have more of our, our demands and our needs to be heard from the policymakers. I think I'm about my time, or can I use some more time? I'm just seeking your advice, or should I?
No, thank you, Dr. Kazi. I think we should pause here. We have a question for you about, it seems like in Pakistan and in some of our other countries, there's a really strong task force. And the question is about, was the task force strengthened by the presence of women on the task force? Is that part of how they ended up being so strong?
Yes. So, initially we didn't have women, so I'll be very frank and honest. But we were, it was additional, it was a very intentional addition of, somebody who knows about gender-based violence, somebody who knows about MNCH, and, our UN agencies were put in there. which are fortunately some of them which are like UNFPA head is women at this time. So yes, and then we have some other champions. So it was balanced out, and we had more of the women sitting in the task forces, and those women are really kind of a voices, because they can really present the case, and they can talk about why it is important. Because the thing that keeps coming back, oh, we are fighting with the virus, why do you think it's important to talk about family planning? And it is something like always put on the cold storage. But this kind of a data sheet, which is really being shown at this time, this is where you will be landing. The baby boom, the kind of, you won't be able to handle the kind of the disruption impacts. So yes, including women in the task forces has really made the difference.
Thank you so much, Dr. Kazi. So we're gonna pause briefly. Everyone, please, stay in front of your computers while we now switch over to our panelists who are speaking in French. So Lou, please switch over to the French channel if you have not already done so. No one else needs to do anything. And then we will begin with the French portion of our discussion.
Thank you very much. I'm happy to see that there's a French portion. It doesn't happen every day. I'm even more happy to be presenting our colleague Aminata Badiane-Toyer from the National Alliance of Youth for Health, Reproduction, and Family Planning in Senegal. And I'm inviting our colleague to talk about a very interesting experience as a young leader for Senegal.
Lou, so I'm so sorry.
Aminata.
Hi, Lou. Sorry to interrupt you. We're having some issues with the translation. Can you just pause 1 quick second? Sorry about that.
Bismillah, bonjour à tous.
Hey, good morning, everyone. I'm just going to ask that we change the slide.
Lou, please go ahead. We'll try to figure out the issues as we go.
Okay,
I don't want to hold us.
I think that you can start. I ask that we change the diapo, the slide. Hello, everyone. Hello to all participants to this panel. Congratulations to all the other panelists for the clarity of their speeches. For Senegal, I'll say that like other countries, we developed a strategy of response to COVID-19. And for the essential, it was made on what has been done in other countries, confinement, closing of the schools, reduction of transports, etc. And for that was to avoid the spreading of the virus in Senegal. But we're going to say this strategy with a little dose of realism, because the risks of morbidity linked to other diseases and mothers and kids and teenagers. And as far as organization, we took cognition of the challenges that was given to us, but our knowledge and also the direction to share the perturbations of these measures would have on the health, the sexual health. And for us, it was an alarm signal that brought us to plead to have a small campaign that was mainly digital, so that the sexual health would be integrated in the health services, and these services would still be provided. in that sense, we had, after this small campaign, some surveys that we're putting on the field, and there's surveys of follow-up of analysis to give us some conclusions linked to the COVID-19. And we can share here the first results, the first tendencies of this survey, mainly with the youth, because they're the target group that participated majorly at the survey. And the main difficulty was a loss of revenue. 57% of the young people spoke of that money loss is linked to stop of the work, and especially for the 25, 34 years old. And also the other difficulty is less frequentation of services linked to COVID-19, and 18% spoke about the fear of going to sanitary services, and also the difficulty to access the services to sexual health, reproductive health services. And also other problem was 18% said about the suspension of the courses as a difficulty. Services have become non-accessible for people that don't have COVID-19. Myself, I lost my father because of the difficulty of access to services, said one of the respondents. Another comment was that many young person need services of sexual health and reproductive, but in this context, it's impossible even to pay the tickets for consultations and also the treatments that are expensive. So if we're concluding quickly, we can say that because of the first tendencies of the surveys, two main problems. First, to have the services, the disponibility of services, concerning that people don't get the treatment they need. It's often for a question of economy or financial reasons, and that has been strongly highlighted in that survey, and that the expense will be put on things, more priorities like lodging or groceries. So when it comes to services, it's a lack of information because of the worries of infection to COVID-19 that has been said by the first panelist tonight, and an establishment of health, and that asks people to have some initiatives specific to the World Health Organization, and to get the proper healthcare. Also, we also tried to gather some information on initiatives or good practices that have been developed, and to lower the impact of COVID-19, to also find solutions and share them. But right now we don't have the time to go through that. But we'll go directly to recommendations that we have developed following the tendencies of this survey. The recommendations that we're giving to the World Health Organization is to have a transversal integration of nutrition in the directives as far as the disponibility and utilization of reproductive health services, whether it's for maternity, neonatality, infantile, and for teenagers and youth. We also want to have that this has not been integrated from a transversal way, and because of the pandemic, it's even more acute problem, the risk of malnutrition for kids and women and teenagers. A second recommendation, we gave a direction that we must have some priority intervention in reproductive health for youth and teenagers, and it will be to put in place a minimum access dispositive for sexual health services that for them that have been forgotten by the World Health Organization, and they're exposed to poverty, to exploitation, to sexual abuse, to violence, and this is why we've got so many infections, HIV, and more risk taken sexual activities, integrated the linked with other sectors. That's also important. I think all panelists spoke about that. Nutrition, protection of the youth, protection and information on HIV/AIDS, and this is also affecting reproductive health. And the last recommendation is to mobilize resources to have the financing and continued services for sexual and reproductive health with humanitarian plans and cash calls, so that we can deploy some social intervention to better the health of women, of kids, of teenagers. For the Ministry of Health, our recommendations to put accent on the question of what is reduce the obstacles to the access of health because of COVID-19. Two actions possible: dynamic application of the multi-sectoral approach and pleading for reactualizing the unique national register so that the programs of social health can be more efficient, especially when it comes to the question of nutrition. And because since COVID-19 is there, the poverty has been bigger. And so there's a need to renew the information and renew the programs, and also using protocols for the minimum access of services of sexual and reproductive health for teenagers and youth, encouraging that the youth, the implication of youth in putting in place a committee, technical group for the coordination and the continuity of essential services in response to the pandemic, and better integration of the civil society and delegating the tasks with implying that all the local elected people can be involved to reduce the difficulty of access to community services caused by COVID-19. The civil society time is running and there's so much information, but for recommendation, I suggest that people read it. Anyway, we will share the slides after the webinar, but we had many questions for you that are asking, how have you made this quantitative analysis on the access, so on the impact of COVID-19 on family planning? How did you measure this impact? That was one question that came back many times. Absolutely. Like I said, it was to do a campaign of pleading, and this campaign had a mechanism of follow-up. And it's difficult to have impact studies because it asks for a lot of resources and time. So we would adopt surveys, and that the surveys was the first thing. And the survey, we made it in a tool of collect that was very accessible. We shared the link with the group WhatsApp to our the people we knew, and what was the impact of the COVID-19 as far as difficulty for in the population. And we just shared the first tendencies, but there's also other target groups that answered to the survey. Thank you. Thank you, Aminata. We could talk for a longer time, but we still have Dr. Amar Sa, the Director of Ministry of Health and Social Action in Senegal, that is waiting for us. But first, I'd like to thank you for your intervention and for your efforts, very important efforts as far as Senegal, for the youth to make sure that they have access. Thank you, Aminata. Dr. Amar Sa, are you with us? Yes, hello, I am there. I'm there. Good morning, doctor. Like I said, we have around 6 minutes to talk about the situation and guidelines from the Ministry of Health. We're listening to you. Thank you to be with us first. Thank you. Thank you to let me give me a chance and give Senegal a chance to participate in this very important meeting. So, as you say, Senegal has a plan that has been made based on the disponibility and the continuity of services we have done on a situation analysis that we did for 6 regions. What is the state of the services in the context of COVID? And on that basis, we've made a plan following the canvas, the guideline of the World Health Organization with 7 pillars. I don't think I need to come back on those pillars. I think everybody knows those pillars from the World Health Organization. The key actions that permitted to give disponibility and services for the sexual and reproductive health, those are following points in our plan. There's an important activity that is having a guide that is given for the essential activities to lead in a period of COVID at all levels, as far as the intermediate or of structures of references. So this guide has been made and it's being testing. We've tested it in a region, an administrative region, and the testing is going on, is going through. After the testing, we'll finalize the guide and then disseminate it to send it in all 14 regions. So we already have some training so we can share this guide. And this guide will give us made so that we are on the essential activities to maintain the services that we had before the event of the pandemic, COVID-19. We also, in this plan, put in place some very performing disposition to take in charge emergencies from the community. And we have this community approach in this plan, and this will be effective for the orientation at the community level. We also put in place some strategies using the phone lines at this level. When it comes to responding to the needs of teenagers and youth, we also had many interventions that are already going on. We reinforce collaboration with the Youth Association, the sectors of education and of youth in the district. My predecessor insisted on this collaboration to touch the youth, and we have to work with them, reinforce their communication to get to them, and to also reinforcing communications on the management of COVID-19. And we targeted our communication towards the youth so that they could understand the utility of using the services of the SRAJ in the COVID period, if only to gather some information that they can have responsible attitudes towards their sexuality. A reinforcement of communication on social networks, because we've got a group of bloggers that we've formed, that we trained, and there's bloggers going to be working on the social networks. We also have some groups, WhatsApp, Facebook, and we're using all those networks to touch the maximum of youth and inform them. We also, on the communication, mass communication, with radio and TV to have some commercials to encourage the youth and the teenagers on the barrier actions and the recourse to make sure that they have the proper recourse and to target youth in a multi-sectorial approach. And this is how we've put it in place far before the epidemic of COVID-19, and we'll continue to reinforce this collaboration, multi-sectorial, to the youth. Now, concerning financing of this plan, we add some financing from this financed 72% by different agencies, World Health Association, UNICEF, the World Bank, and after that we're gonna sharing with the people from Senegal, and all the partners were asked to participate to the financing of this plan. So I'd like to thank them for the solidarity. Of course, the country of Senegal also with its budget participated, and we also have some local participation with some community organizations that manage resources through the effort of health. So what we call the committees of sanitary development, former Council of Health, and they are helping a lot to the execution of this plan. Of course, there's still a gap that we need to fill. So there's about 25% of the budget that we still need to find. And we're calling various partners in Senegal and asking them to invest in this plan that will permit us at least to maintain the what we had before the pandemic of the COVID-19. So with the reduction of the mortal maternities, which is still very high every year, the reduction of the mortality to kids, but especially the augmentation of contraception, and to make sure that all needs are being satisfied. So this is what I wanted to present you. And I am there ready for question eventually. Thank you. Thank you. Thank you, Dr. Sa. So you really took leadership as far as the guidelines. It's really essential. And there are many questions. Unfortunately, little time. So I'll just ask one question that has come back. Come on. because most of the questions that were asked are relative to the youth. Maybe some colleagues that thought that the youth didn't have enough attention in the plan of Senegal. And there was a question that was asking if schools in Senegal are closed, how can you reach the youth? Is there a strategy to reach the youth that are not going to school? Yes. In Senegal, there are some youth that are in the formal schools, and the schools are opening up. They were closed, but since last week, the youth are in a class of examination. Their classes have reopened. So we have access, but we also have strategies to find the youth in other reunion places, gathering places, because we're in the summer, so the youth are on the beaches, and also the youth that are not in formal school, that are in informal, and that also in other sectors, and we are organizing to find them and to reach to them. And in Senegal, we already had put in place instead of the health direction of the youth, a division charged only of the health of teenagers. And this division is working with other sectors. And we're making sure to have an action plan with the ensemble of sectors and activities. And I think that is with a very good experience in Senegal that maybe other countries can be inspired by. Like we are making sure to find the youth where they are, so to give them the information they need. Super. Big thank you for sharing. We'll also share the plan of Senegal and the slides and what you just shared with the entire group. I will go now for the English, another English portion.
Thank you so much, Lou. Thank you so much to our presenters, Dr. Omar and Aminata. I'm going to turn it over now to Lou to just lead us through some preliminary gaps and a review of concrete actions. Just pausing quickly to say that we are switching over translation. So panelists, you don't need to do anything, but just we're giving our translator a moment to adjust. And then Lou, who is a consultant for public health at PAI, welcome, and please lead us through the preliminary analysis of the gaps and concrete actions. Thank you.
Thanks so much, Delie. Can you hear me?
Yep, loud and clear, Lou.
Great, okay, thanks so much. Now that I'm thanking, I first of all would like to thank all the presenters for the tremendous and interesting presentations. I think, or at least for me, the presentations clearly show how complex the process is, from developing these guidelines at the top level at WHO all the way to domesticating them and taking them to the sub-national level. All of this obviously to ensure access to sexual and reproductive health services and information. I think in an effort to make some sense of this complexity, together with a group of partners, some of them, I mean all of them here on the panel with us, FP 2020, AFP, JPIGO, and PAI, we took a very careful look at existing guidelines, and not just those at the WHO level, but also those that were developed by countries and those that were being sent around by organizations. And we learned an enormous amount, but we also saw that there were some opportunities to maybe make efforts a little bit stronger. because the analysis, or the initial analysis that we did, really brought some opportunities to light. And these opportunities is what we're calling sort of optimization or optimized guidelines. And we're advocating for these to ensure even greater equity and access to essential reproductive health services and information. Unfortunately, the analysis is not fully ready yet, but we will be sharing it with you in the coming weeks for sure, and we'll be sending it out to the participants on the webinar. Because very importantly, these points for optimization also provide key entry points for advocates, and that is where all of you come in, obviously. And we really feel that the stronger we manage to make these guidelines and the processes that ensure their adaptation and financing and implementation, the more we will be able to sustain health outcomes beyond the current crisis and be prepared for future health threats, but not just future health threats, but also maybe maintaining some of these essential service practices that we've been fighting for and that have maybe been accelerated through the current crisis. So maybe a little bit of a silver lining on these gray clouds of the current pandemic. And we think that's sort of an optimistic and a positive way of looking at what is currently going on. Some of the opportunities for optimization that we have found in the various guidelines, I tried to put them under these 6 themes, but they don't cover it. But we really did see a lack of looking at these guidelines, or a need to look at these guidelines through a youth and adolescent lens, because they have such unique and specific needs. And we would really like to advocate that they come out stronger in existing guidelines, but also very importantly that youth are involved in the development and implementation of these guidelines. And I think that's where Aminata's example from Senegal, where the youth really took a lead in getting the data and getting the evidence for this advocacy, and showed that youth were not accessing services is really essential. Obviously, in a lot of the guidelines, there was some talk about adapting service delivery models, but we feel that these could maybe be strengthened, and also the role, especially in the countries that a lot of us work in, giving essential health worker status to, for example, extension workers or community health workers would be key, but also underlining in guidelines sort of the importance of rights of patients and clients, and the importance of privacy, because that is something that we've seen with COVID that privacy is not always safeguarded. We were very happy to see that WHO did provide some guidelines on safe abortion care and post-abortion care. We would like to underline that for countries that are adapting these guidelines to their local context and their local laws, and we can't stress enough how important abortion care and post-abortion care is in times of crisis, when women become even more vulnerable. And obviously, this also includes very young girls and adolescents. Another area where we could see optimization is that guidelines are more mindful of marginalized people, including those in humanitarian emergencies. There's currently 55 or 51 million internally displaced people in the world. They lack access to most services, and their lack of access to reproductive health just compounds the tragedy, which is aggravated by the current crisis. Number 5 is, or the 5th one on my list, is that guidelines should really not remain on the shelf. And that's something, unfortunately, that we often see. So how do we really ensure as a community that these guidelines are adapted and implemented? And obviously that there's a need for them to be financed. And that's, I think, also where Dr. Yasmin said that budget advocacy was so important, and I think that's also where advocates play a key role to ensure that these guidelines and action plans that result from them, however good they are, they will remain on the shelf unless there's financing available to implement them. And then, and this is a point that was also stressed by Aminata and also by James, that sexual and reproductive health obviously does not occur in a vacuum. The crisis really calls for integration and for programs to mutually reinforce each other, whether it's with the nutrition agenda, with the neonatal and maternal and child health agendas, but we need to complement each other. We're currently not competing for resources. We should be putting our heads together. So this slide, or the slide that is up now, is where we're really advocating for optimized guidelines. This can be done in a number of ways, and ways that advocates know very well. It's by keeping a firm finger on the pulse, like Aminata, going out, gathering the data, communicating the data, and holding governments accountable to what they've committed to in the past. But in a positive way, by being part of the conversation and by being a perfect partner. We're all in this together. We just need to make sure that those people that we're talking about, whether it's youth or marginalized people or women, that they're part of the solution and that they're with us around the decision-making table. Following the money is absolutely key. Without the resources, as I said, not much will change. And something that also came up in a couple of questions that were raised is that we should really try as a community and as advocates to sustain health outcomes beyond the current crisis and learn from what we're doing now so that we have guidelines available and can more rapidly roll them out in case that there is a new crisis, or even with no crisis, ensure that the gains in maintaining essential health service practices are maintained post-COVID. Now, these are sort of the broad pointers for advocates that we all know, but the analysis that we've done with the team and with the group of organizations have also unearthed very specific objectives that advocates can tackle, whether that's advocacy around eliminating client payments, around the adolescents and youth lens, or ensuring that RNMCAH supplies are on the list of COVID-19 essential medicines. These are all issues that CSOs and advocates are ideally placed to help tackle and to bring to the forefront. And I think together with all the stakeholders and partners, we'll be able to fight, all of us, against this and ensure that everybody has access. So that's it for me. I tried to rush it a little bit so that we could remain on time. Billy, I'm sorry we went 2 minutes over.
No worries, Lou. Thank you so much for taking us through this. We do have a question for you. So can you just talk through what agencies participated in the committee to develop the essential global, national, and subnational guidelines? And can a list be supplied?
Definitely. The group of organizations that took on the initial analysis was being had FP 2020 in the group, AFP, JPIGO, PAI, and sort of those were the core group. But we welcome any input, obviously, and the group is not confined to just those 4 or 5 organizations. So anybody with an interest can join. The work is not yet finished. And the analysis is foreseen sort of somewhere midsummer. So I would think, yeah, by the end of July, we will definitely be able to share the detailed analysis.
Perfect. Thank you so much, Lou. So we're now at 8:33. I know we're a little bit over time, but I want to say a really big thank you to all of our panelists for sharing their insights, from sharing what is happening at the country level. And also thank you to Lou for sharing insights on gaps and concrete actions that we can take moving forward. I don't want to keep you much longer, but we will share this recording. As Lou mentioned, there is an analysis that the group is working on, and when that is ready and published, we will also share with the participants of this call. So once again, thank you so much for taking the time to talk with us today about the WHO guidelines and how we can use them to keep SRH prioritized, and have a good day to everyone.